La charla también está disponible en español, solamente necesitas apretar donde dice interpretación y elegir el lenguaje español para la traducción en vivo.
Good afternoon, everybody. Thank you so much for joining us today. I'm Molly Davis, WFDD's Assistant General Manager. Welcome you to the fourth installment of our series of virtual community conversations. Today's topic, what you need to know about COVID-19 vaccines. We know this is a subject on a lot of people's minds, and we are really, really happy to have some wonderful experts here who can tackle some of your questions. These events have been so important to us, especially during the pandemic, for helping us maintain an engagement with you, our listeners, and our community. We are so appreciative to you for being here. Your support and your engagement makes all of this possible. We also want to be sure that we say a big thank you to our sponsors of this event. We are so appreciative of you for supporting us in this endeavor. Thank you to Great Outdoor Provision Company, the Hispanic League, Brook Ridge Retirement Community, and Eben Concepts Employee Benefits. Thank you so much for supporting this. Now I want to turn it over to WFDD's Assistant News Director, Bethany Chafin, who's going to lead us through this conversation. Thank you so much, Bethany.
Thanks for those remarks, Molly. And I just want to say I'm so happy to be with you all who are tuning in, and I'm happy to also have an opportunity to introduce our panelists who are with us today. First, we have Dr. Mandy Cohen. She is Secretary of the North Carolina Department of Health and Human Services. She was appointed to this role in January of 2017 by Governor Roy Cooper, and you have likely seen and heard a lot from her over the past year or so because she and her team have been expertly guiding the state throughout this pandemic. We're so happy to have her with us. Also from NCDHHS, we're happy to have Dr. Michelle Laws, who serves as Assistant Director for Consumer Support Services and Community Stakeholder Engagement for the Division of Mental Health and Developmental Disabilities and Substance Abuse Services. Dr. Laws is also DHHS Historically Marginalized Populations COVID Response Team Lead. She has a long history of working to improve health outcomes and eliminate health disparities. We're so happy she's with us. We also have Dr. Iulia Vann, and she is the Guilford County Public Health Director. She's been with the department since early 2019, and Dr. Vann's expertise has helped expand services in areas such as communicable disease, refugee health, and she has certainly helped to facilitate extensive community partnerships throughout her work. Thank you for being with us. And we also have Wake Forest Baptist Health infectious disease expert, Dr. Christopher Ohl. Dr. Ohl has a career's worth of experience in planning for and responding to emerging infections. He's a member of Wake Forest Baptist Health's COVID task force, and he serves as an advisor on COVID for various local government entities and businesses. So thank you to our wonderful panel. We're so happy to have you here with us and have this conversation. So we appreciate it. And I'd like to begin with this question, and I'm going to first address it to Dr. Cohen. Lately, we've seen that North Carolina's COVID numbers have been trending downward, which is great news. Do we know exactly what we might be able to attribute this to? Wondering, perhaps, is this that we've simply gotten past a holiday surge, or is this perhaps, that maybe we're beginning to see the very early stages of the impact of a vaccine rollout?
Well, first, thank you so much for having me and my team member, Dr. Michelle Laws, with me today, and well as others, to have this really important conversation. And we are pleased to see our trends heading in the right direction, but I would caution us because those numbers are still pretty high. I think we almost get a little desensitized because it's been such a long year of high numbers of COVID cases. But we're seeing them trend down. We're seeing our hospitalizations trend down, which is a great thing. In North Carolina, through this whole year, we never overwhelmed our healthcare system, which is a really remarkable achievement considering what we saw in states even just next door to us. When we would get calls to say, send us ventilators, we never needed to do anything like that in North Carolina. It's great. Now, I do think we saw a spike at the beginning of January. That was our highest peak of the whole pandemic after the holidays, as you mentioned. And I do think we're coming down after that point in time with the holidays and all of that travel and getting together really does matter. So the 3 W's are as important as ever. I do think that by us focusing our vaccine efforts on those who are over the age of 65, that is starting to help from a perspective of the impact of who could die from COVID. It's exactly why we started with those over 65. People over 65 actually represent 83% of the deaths from COVID in North Carolina. 83% are over the age of 65, and that's who we're vaccinating right now. Unfortunately, deaths is a what's called a lagging indicator. It actually takes a really long time for us to see it. Some of the actions we're taking really show up in lower death rates. So actually in the last few weeks, we've seen some of our highest death rates. And I think that's a holdover from what we were seeing over the holidays. So I'm hopeful as we get more into February and certainly into March, I think that's when we'll first start to see the impact of our vaccine efforts.
Wonderful. Thank you so much. I know a lot of people are closely watching, waiting for their group to come up, especially group 3. A lot of people are anticipating that. I'm wondering, what needs to happen before we move on to vaccinating the next group of individuals in North Carolina?
Yeah, great question. So again, as a reminder of who we're vaccinating right now, we're vaccinating all healthcare workers, all folks who are living in nursing homes or other long-term care facilities, as well as if you work in those facilities. And we're vaccinating those who are 65 and older. Next up are our frontline essential workers. Those are folks that have to leave their home to go to work and are in some particular industries. Our teachers, our firefighters, our police officers, our clergy. That's who are coming up next in the next group. But we still have a high demand from those who are over 65, but we're watching it day to day. And we're seeing other states are now moving on to some of their frontline essential workers. So I'm hopeful within the next couple of weeks that we'll be able to move there as well. It doesn't mean we'll stop vaccinating those who are 65 and up, but just open it so that more folks can get access to vaccine.
Great. Thank you so much. We actually have a question from a listener named Elizabeth. She's asking why individuals with intellectual and developmental disabilities, as well as additional risks like her adult son who has Down syndrome, might be so low or farther down on the vaccine list. And we can open that up to anyone, but Dr. Cohen, if you had any comments on that, we could start with you.
Sure. Well, as I mentioned, the reason we started with those who are 65 and up and those in our nursing homes is that's where we are seeing those who are at the highest risk of death. I already mentioned 83% of our deaths, unfortunately, come from that segment of the population. So that's why we started with 65 and up. The next group, as I mentioned, are those frontline essential workers. It's just a few industries that really can't stay home and are so critical to keeping our worlds running, our kids in school, our streets safe. And so those are the folks who are next. And then folks with those chronic diseases are right next. And so, it's really hard to prioritize this precious and scarce resource. And, I'd love to be able to get vaccine to everyone all at once. And in fact, our vaccine providers are able to administer way more vaccines than we have. They're probably able to administer 3 times as many vaccines as what we get from the federal government. So our limitation at this point is not on the operations. It's really just on the supply of vaccines. It's really, really limited. And that's so hard. And I know it's really frustrating for folks. So what I would say is we are advocating every day to the federal government, send us more. We are ready. We can take on more vaccine. And so, we're going to try to move quickly through our frontline essential workers. And that's when we will get to those with some of those chronic diseases that also put them at higher risk before we're able to get to sort of the general population of folks.
Wonderful.
And
Thank you so much.
may I add, Dr. Cohen, we are capturing some of the IDD populations, right? So when we think about the IDD populations in group homes and ICFs, eligible homes, they are in group 1 as long-term care facilities. And then we're also capturing some of the IDD, intellectually, developmentally disabled populations in the shared housing with 2 or more individuals receiving HCBS. It's also considered LTC, long-term care, and eligible in group 1 as well. And then we know that we're capturing a large percentage or a significant percentage of our IDD population in group 2 in the 65 and older. So it's not like we're not vaccinating that population at all.
Thank you so much. And I do want to apologize. I believe that question came from Deborah rather than Elizabeth. So thank you, Deborah, for sending us that. I'd like to ask you all about something that I've been very curious about in this process. You know, we hear a lot about the protection that a vaccine can provide in terms of, you know, symptoms and disease and avoiding hospitalization and death, hopefully. What do we know at this point about how a vaccine could affect transmission rates for COVID-19? And I can open that up to anyone, but maybe we could start with Dr. Ohl, perhaps.
Well, this gets at that question that keeps coming up about herd immunity and how much herd immunity we need. And depending who you talk to and when you talk to them, you get a different number. So you need a certain amount of the population to become immune to protect the whole entire population as a whole. And the number being bantering about right now for COVID with the considerations of new variants is around 80 to 85%. So that's a lot of people. However, if you think of it as like a virus going on a mud run, and the thicker the mud is, the harder it is for that virus to get through it. And the more people who get vaccinated, the thicker the mud's going to get, and to a point where it reaches almost a tipping point. So the short answer is it's too early now, but I think somewhere around when we get up into March and April, as vaccinations really get ramped up and we start getting people who are out on the front lines more, who are involved a little bit more in transmission, we might see an effect. So you know, I agree with Dr. Cohen. The drop in numbers right now that we're seeing is not a result of vaccine yet. And so they have to hang in there a couple, 3 more months for that.
Thank you so much. I do want to remind those of you who are viewing this conversation, if you do want to ask a question, you can use the Q&A function in Zoom. That works a little bit better than the chat function. So we appreciate you sending us what you want to know. So I'm going to address another question to Dr. Cohen. Her time with us is a little bit more limited today. But wanted to ask, you know, a lot of our listeners leading up to this event have been sending us scenarios. You know, they're talking about varying levels of you know, those who have received vaccine within their family. Say grandparents now have been vaccinated with both doses, but you know, parents have not and grandchildren have not, and they're wondering what it is safe to do now. So I'm wondering, how do we navigate the next months when, you know, different people in our population are going to all be at a different place as far as whether they have been vaccinated or not?
Yeah, what a great question. And I know many families are going through this right now, as it should be. Grandparents are getting vaccinated, and I'm so grateful for that because they are at the highest risk. And as of right now, there are no vaccines that are authorized for any children under the age of 16. We know that they're doing ongoing clinical trials, so that will be some time to come. So we are going to be in this period of time where there are going to be some folks who are vaccinated and some that aren't. So our recommendation is for folks to continue with the 3 W's, right? The wearing of a face covering, waiting 6 feet apart, washing hands. And the reason is a couple, you know, one is that the vaccines are not perfect. We know this, even with 95%, which is way more effective than I will say I even thought we could get to with a vaccine, which is fantastic. That means that they're still not perfect, and you still can get COVID, and we do want to protect each other, particularly as we're trying to get to, as Dr. Wall mentioned, that herd immunity or whatever that higher level of vaccination is here in North Carolina. I think you are going to see us stick with the 3 W's, particularly through the next winter months and into the spring, so that we can protect each other, because there is still way too much virus here in North Carolina. and not enough people who are immunized at this point. So the 3 Ws are going to be with us. Those masks are going to be with you, and making sure that we're following those protocols in terms of protecting each other. Is going to be something we're going to be doing for a number of months. Now, I hope we will be able to lighten up on some of those as we get into the summer and we understand things even more. However, I would caution everyone to say that we are still learning about this virus every day. We know this virus is changing, that there are some variants in the virus, which may have different impacts, may make that virus more contagious, could make you sicker if you get it. Those are the kind of things we're still learning. So it's important to keep checking back for good information, back to our department, back to the scientists that are advising us as we go through there, because things are going to change as we learn more, as we have this whole year through responding to this pandemic.
Thank you. While we have a representative from both the state and the county level, we have Paige who's asking, is supply being distributed in an even way between different states, and is North Carolina getting its fair share from the federal government? So I wonder, Dr. Cohen, if you could start with that, and then Dr. Vann, maybe if you could talk about allocations as far as Guilford County goes and what you've been seeing.
Sure, I'll start with how we at the state get our vaccine from the federal government. The federal government allocates to the state based strictly on population. So we do feel like we're getting our fair share, but again, the supply is incredibly limited. There are not enough vaccines to go around, but we are getting our fair share in North Carolina. And then we at the state level, we tell the federal government where to ship those vaccines. And the way we are doing it is basically to say, we are doing similar to what the federal government is doing. We're just looking at population of the county, and then we are distributing it based on the population of the county. We are giving slightly more vaccine to counties that have a higher proportion of those who are over 65, right? Because that's who we're vaccinating right now. And a higher proportion of serving historically marginalized communities, our African-American communities, Hispanic, Latinx, American Indian, because we already know we are behind in terms of vaccinating our African-American population, Hispanic. So we need to make improvements there. Our data is now very clear on our dashboard down to the county level. We are not doing as well, and we have a lot of work to do to make sure we are equitably distributing this vaccine to our underserved population. So we are giving more vaccine to counties with larger African-American populations, larger Hispanic populations, but largely it is based on population. And then we do support some of additional events, and I bet they'll talk about that in the Greensboro area, that are really reaching our underserved communities. So when we see those kinds of events, we want to support them at the state level. Though I will say it's really hard to support all of their fantastic events all over the state. We wish we could support if we had more vaccine. It's just really hard right now because we just don't have enough. But that's how we are doing it. It's largely population, a little bit focused on how many folks over 65, how many folks in underserved communities are you supporting in the county, and making sure we're really thinking about our underserved communities.
Thank you. Dr. Vann?
Yeah, sure. And I can pick it up from here to talk a little bit about the county distribution. So just like Dr. Cohen mentioned, we are getting a weekly allocation based on the population. Guilford County is the 3rd largest county in North Carolina. So that allocation is proportionate to our population. We also receive an equitable distribution of the doses based on those criteria that Secretary Cohen mentioned, because we do have a higher number of people living in Guilford County that are 65 and older. And then we also have a larger population of historically marginalized populations. The week before, we've also received close to 5,000 additional doses for our large scale vaccination process, especially the one at the Coliseum, the Greensboro Coliseum, that we're running in partnership with Cone. So we were able to, between the two of us, between Cone Health and Guilford County, we were able to distribute more than 10,000 doses the week prior. But we also know that there are several other places in the state that need additional doses. So we know that these additional allocations will be rotated through the state for that equitable approach. within our own department, because we do know that we need to be equitable and because we need to reach our historically marginalized populations. From the very beginning, we've started having a very intentional approach in the way that we're scheduling those doses, and the way that we're making the appointments and the vaccine available to those communities. So we know the distribution, the demographic distribution of our county and those demographics. And we said from the very beginning that at least 35% of those appointments will be made for our Black and Brown communities, Latinx communities, and refugee communities. And we have been extremely intentional and focused on that. And I think that through that effort, working with our faith-based community, our other community-based organizations, we were able to reach some of those goals in the weeks that we have been looking, and the trends that we have, with last week having approximately 37.7% of our appointments in those marginalized community that we have across Guilford County. So we're continuing to do this work, and we are continuing to prioritize some of those appointments to make sure that we're intentional and equitable.
Wonderful. Dr. Laws, I wonder if you could pick up on this conversation and comment on, what we're hearing about the fact that we have some work to do to reach some of these historically marginalized communities, and, what kind of outreach is being done at the state level as well, but also, what are you hearing? What are some concerns? What is the dialogue like right now?
Thank you. And I want to say it is an honor to be here with the panelists, and this is my first time sharing a panel with my boss, Dr. Cohen. So it is an honor to share this platform, and also want to recognize the work that we do through the historically marginalized population work group that the secretary really asked at the beginning of this pandemic, that was set up so that we could be intentional about how we were looking at COVID's impact on historically marginalized populations, is led by Deputy Secretary Ben Money, who he, along with myself and many other members of that team, spent quite a bit of time trying to engage historically marginalized populations that we identified by race and ethnicity. So African American and Black, Hispanic and Latinx, American Indian populations, and also immigrant, refugee populations, and our behavioral health populations as well. Some of the things that we've been doing is having quite a lot of listening sessions with these different stakeholder groups. The secretary participates in roundtable discussions with specific HMP population subgroups within our state. And also, in addition to the listening sessions, really allowing space and opportunities for people who are working in these communities, community-based organizations, faith-based organizations, to let us know, to alert us as to what's working and what's not. And so what we've heard, some of the things that's not working is, or that we didn't do a great job with on the front end. And that was, we had to balance in terms of the vaccine, speed versus equity. And it wasn't pitting it against each other, but it was really trying to get as many people vaccinated as we possibly could. And at the same time, recognizing after we saw the first distribution go out, that equity also needed to be built into that on the front end. So we've heard loud and clearly from stakeholder groups, where we are now is where we should have started. And so that's some of the things that we're hearing. We're hearing that those that were greatest had the greatest impact and were disproportionately impacted by race and ethnicity in terms of cases and in terms of deaths should have sort of been baked in on the front end along with the speed. Well, as you can imagine, our goal was to get people vaccinated and to make sure that we were hopefully, and that's what we sort of focused on, hitting those populations as we were focused on the speed factor. And so that's one of the things we're hearing is that, equity should have always driven, and it's not like it didn't drive, but we learned some lessons along the way about how we needed to be more intentional. We're also hearing on the ground that community-based organizations and faith-based organizations, they need the resources. They want to be partners. They're raising their hands. They're, saying we want to be partners. We want to be vaccine sites. We want to work with our local health departments and our medical facilities. We want to help you do this heavy lifting and get those underserved populations vaccinated. But it takes resources. And so we're hearing different barriers and challenges that we're working through and exploring and kind of thinking through. What does equity look like on the other side of the pandemic? We're hearing that, and we knew this, some of us, I myself included, who worked in the health disparities or equity space for a while, we predicted what was going to happen in terms of COVID's impact, who it was going to hit the hardest. We knew that people coming into this pandemic that were already impacted disproportionately in terms of the economic impact, in terms of access to those that fell in the Medicaid gap, for example. So the uninsured. So in terms of access, we knew that these populations, rural populations. So COVID shined a light on the fault lines of our system, our public health system, our medical health system in rural communities and the like. And so we're also hearing, how are you all going to address those social determinant impacts? And we all already are, with a lot of the work that we're doing through NC Care 360, through our community health workers, getting people connected to services and the like. So those are some of the things that I'm hearing from the communities that we've been engaging.
Thank you so much. I appreciate that. We have just a few more minutes with Dr. Cohen. So I'd like to address this to you first, and then we can open it up to our other panelists as well. But, a lot of questions about the safety of this vaccine and the fact that it uses, mRNA. It's kind of a new type of vaccine as far as a public rollout. And even though it's been researched for a long time, we don't have some of that long-term data. And, what can you tell individuals who have questions about, they know that it's effective against COVID-19, but they're curious about some of the possible long-term side effects?
Yeah, I think those are great questions. So a couple of things. One is that science had a head start here. So I know vaccines came to market quickly, and the fact that we have vaccines rolling out to more than 1 million people in North Carolina within a year of this pandemic started is really remarkable. And the reason is because our scientists had been working on this kind of a platform and this kind of vaccine for many, many years, and had been working towards this point, which is great. And then we did many trials, clinical trials and research to make sure that we understood how this vaccine would work and what would the side effects be in the short term, in the medium term, and the long term. And so those trials continue to go on for folks to understand what are the longer term impacts of the vaccine. And the good thing that we are hearing is that we aren't seeing serious side effects, and that is great to hear. Folks are getting pain at the injection site. They're feeling crummy, for about 24 hours. So you do, there are some side effects, but they do seem to be very short term. And like I said, the effectiveness of these vaccines is more than we actually had thought, being 95% effective. And I'd encourage folks to, know that there are more vaccines that are coming to be approved by the federal government. And so we hope to have even more vaccines for folks to be able to take, because our supply is so limited right now, having more vaccines out there will be great. But again, rigorously tested, evaluated by our scientists, looked at all the side effects, continue to look at the side effects as we go on. And now we have more than 1 million people in North Carolina who have gotten the vaccine. So, we really have quite a large number of people now who have experienced this vaccine. So encourage everyone to do their homework, go to yourshot.nc.gov. We have a lot of scientific information, as well as testimonials from a lot of different folks about their vaccine experience. And I think just getting good information is really what it's about. There are a lot of places to do that, particularly go to yourshot.nc.gov for good information.
Wonderful. Thank you so much for joining us, Dr. Cohen. We really appreciate your time. We know it's very precious these days. So thank you.
For having me, and Michelle will do a great job for the second half here. But thank you, everyone.
Take care. Dr. Ohl, I wonder if you had anything to add to that in terms of, again, the long-term data, what's out there or not out there? What are we hoping to learn in the future about mRNA vaccines like Pfizer and Moderna?
Yeah, well, so Pfizer's and Moderna's vaccines are somewhat unique as far as the fact that in the world of licensure, but they've been worked with in phase 1 and 2 trials for some time. So in those group of people, we have information that goes back more than a few years. These vaccines actually were in development to be used for the flu, because every year we have to change the flu vaccine, right? And a large amount of it, we actually grow the virus in eggs, which is like 1960s technology. And so what we were trying to do is get a vaccine where you could insert the genetic material that encodes the proteins that our antibodies recognize. And so they had this vehicle, which is a lipid or a fat kind of emulsion. And they were working with flu. And then when COVID came around, they said, well, let's just pull out the flu and put in the COVID material. And that's how we got our vaccine out so quickly. And so we've had some information about it. As Dr. Cohen also said, I mean, there's been over 1 million people in North Carolina who've had the vaccine. I just pulled the stats up for today. It's 32.3 million across the country. And all of these people are followed so that if there's an adverse event to the vaccine, we report it in something called VAERS, which is the Vaccine Adverse Event Reporting System. And then that goes straight to the FDA. The FDA keeps an eye on this. We can actually, anyone who's an investigative ID doc like me or can interrogate that database and look to see what's going on. That's how we learned that there was a small signal of allergies to both messenger RNA vaccines, Moderna and Pfizer's. But we know that now that it's probably somewhere around 1 in 10 million people who have that allergic response, because we've had so many people who've gotten the vaccine and we can watch that. So fortunately, it didn't turn out to be a bigger problem. Other than that, we've seen no safety signals that imply that there might be long-term adverse effects. And this is particularly important for pregnant women, because it's a discussion that pregnant women should have with their obstetricians about whether or not to get vaccinated. The American College of Obstetrics and Gynecologists says that from their point of view, it's a safe vaccine for pregnancy, and that the benefit of being vaccinated to protect yourself against COVID while pregnant outweighs any potential side effects that you might have. And I happen to agree with that. And we have registries now so that when pregnant women get vaccinated, their information is counted and we keep an eye on it. So more evolving information, but it looks like all good news there.
Wonderful. Thank you so much.
May I,
Yes.
in the event that there are, I often say just plain good old down home folk who often challenge us to make our information on our dashboard whenever I'm presenting information from DHHS. Invariably I'll get someone that will say, look, can you just break that down for me? So one of the things that I say to people among some of our CBOs and just communities, when they ask about the speak, because that was a concern, and particularly of the African-American communities and other historically marginalized populations. I don't know, that was too fast for me. Just want to piggyback on what Dr. Ohl said in terms of people working on it. I often tell them that it's not like the old days when you have a scientist that's staying in the lab by him or herself, day in and day out, they're working. think about it, I often say in this way. If someone came to me, and I always use myself as an example, and they say, Dr. Lyles, you can build a multi-million-dollar home, but you have to use the money that's in your bank account. It would take me at least a decade or two to build a multi-million-dollar home if all I can use, no loans, no extra help, all the money that's that I have, in my savings or 401k or whatever, right? But if they come to me and they say, Dr. Lyles, you can build a multi-million-dollar home and we're giving you that money. And if you run out while they're building it, we're going to give you some more so that you can get your home up. I could probably, I'm from Chapel Hill, born and raised, live here now still. I could probably find a builder in Chapel Hill who, if I said money is not an object, could build me a multi-million-dollar home quicker than a decade for sure, right? And so I tell people that this vaccine, not only did you already have people in the labs working on this mRNA vaccine, but you also had the resources to pull together the best minds at the same time working on this vaccine. And that's sort of what contributed. You need money, you need lots and lots of money to bring something to fruition the way in which we saw this. And the other thing I want to say is the fear. It was a real fear among African-American women, particularly given the eugenics project in North Carolina and other states, that this was some way an effort to cause them to become infertile and to create problems with them being able to have children in the future. And so I'm glad Dr. O mentioned, address the issue in terms of pregnant women, because we've had to allay that concern as we work to decrease hesitancy among our H&P populations. And there were other beliefs and so forth. Yeah, so I just wanted to add that.
Thank you so much, Dr. Laws. I appreciate it. Dr. Vann, I'd like to ask you, we have a question from James who says, are there any concerns about vaccine waste at vaccination sites? If so, how is possible waste being addressed?
Are there any vaccination?
I think the question is, are there any concerns about wasting any doses at the end of the day or the end of the week even? And if so, how are we approaching that to make sure that we use as much of it as possible?
Yeah, absolutely. So I think that it's very clear to us that every single drop and every single dose of the vaccine is extremely important. So the way that the planning goes into effect accounts for every single dose to be utilized. At the beginning of the day, we have a very clear idea of how many people are coming through our vaccination clinics, and we only bring on site those amount of doses. So far, we have not had, we've had very limited number of people that have not showed up for their vaccine. So there have been almost no doses that we have wasted from the allocation that we receive. So we're spending a lot of time and effort and resources to make sure that the transport is up to standard, that the storage is up to standard, as well as the number of appointments that we have in one day to expand all the doses that we have there on site.
Wonderful. Thank you so much. And just a quick follow-up, now that a lot of individuals are scheduling their second appointments or having those scheduled for them, we did have a lot of questions about how closely people need to adhere to that schedule. And from your side of things, I wonder if you could explain, what people need to know about getting that second dose.
Yeah, so absolutely. First of all, the second dose is being scheduled when that individual is within our clinic. So try to make it as simple as possible. While they're sitting for their post-vaccination observation, we have team members that are helping with that second dose appointment. So when they leave the site, they know exactly which date and which time that they need to come back to for their second dose. We also make it very simple. We're not moving our clinics around. So if they received a dose at a specific location, they know that they're going to also come back for their second dose at that same location without having to worry, where is that vaccination clinic going to be 3 weeks from now or 4 weeks from now, just trying to have it as consistent as possible. We also want to make sure that even if we know that there has been some additional guidance from the CDC with some flexibility for those 21 or 28 days for the vaccine, we want our community members to be mindful of their second dose appointment, and we would like for them to be able to stay as closely as possible to that appointment date, because it all goes back to that planning and that dose wasting, because we want to only bring as many doses on site as we need to for that particular day. So we've had a few situations in which our community members showed to our sites earlier than they were supposed to, and we did not have that dose on site for them. And we also received both products, Moderna and Pfizer. So we want to make sure that we have the right dose for them out of the product that is being utilized at that time. We have made it very simple. If anybody would want to reschedule or cancel their second dose because of various different reasons, they can call our line and they can make adjustments to that depending on the time frame that they're under based on the product that they use. So they can call the 336-641-7944 number, and they can go through the automated process and choose option 2 to reschedule their appointment if they need to, and they're still within those guidelines.
Wonderful.
So thank you for that question. It's important to clarify that.
Well, thank you for your answer. Johnson & Johnson has now applied for emergency use authorization for their vaccine. And I'm curious, and this can go out to all of you, what does this rollout look like when we introduce a third vaccine into the mix? And we have had a question from Charlotte who asks, in the future, will we get a choice in vaccine?
No.
Dr. Ohl, we'll start with you.
Yeah, let me take the choice one first. Short answer, no, because it all depends on what your vaccine center is getting and how the second dose is administered. Between the two messenger RNA vaccines, Moderna and Pfizer, there really isn't that much difference between them. And so if it was me, I'd be happy with either of them, and I wouldn't make a choice. Now, once we start getting into some of the nuances of the new vaccines, and I'm going to go a little bit on a limb because we haven't seen the FDA's report or the ACIP's report yet from the CDC, which tells us where to use these. But these vaccines are going to be a little bit different. Johnson & Johnson's, for instance, is rather than use a little fat particle to put the messenger RNA in, it uses a virus that infects humans but doesn't cause disease ever, and it's not competent to do any kind of replicating. But so it's just the vehicle to get the messenger RNA into the person, and then it makes the proteins there. So the efficacy of that vaccine's a little bit less than Pfizer's and Moderna's vaccine, depending on the group you look at, in the 80% somewhere. And there are other vaccines coming out soon, and we'll have to see how those all stack up in the EUAs. But the question people should be asking themselves is it good enough? And particularly with the variants coming around, the thing we really want these vaccines to do is prevent severe disease, prevent hospitalizations, and prevent deaths. And that's the number one thing we should ask of these vaccines. Second of all, we'd like it to slow transmission. And so you have to take those two things into account. So there are other things. Johnson & Johnson's vaccine doesn't have to be frozen, which means you can move it around easier. And all these logistical challenges that we have in getting vaccine to the vaccine site isn't as bad, and you only need one dose, and that helps a lot without having to plan or get the second dose in. So we'll have to see how the ACIP, that's the CDC group that advises on immunization practices, weighs in on that. And so you might see something like the messenger RNA vaccine for people over 65, but for a 32-year-old grocery store worker, you might see Johnson & Johnson or AstraZeneca's vaccine. So it could get parsed out like that. So I really don't think that people need to spend the time to start doing all their homework and research to figure out which one they want. I think we're going to have help from our science organizations in telling us that.
Thank you. Dr. Vann or Dr. Laws, go ahead.
Yeah, I want to just add a perspective from in terms of health equity and what I'm hearing from HMP populations from around the state. So you know, on the is there going to be a choice, and notwithstanding all the excellent points and important points that Dr. Alls pointed out, you know, we don't have border restrictions and boundary restrictions at this particular time when we rolled out Moderna and Pfizer. And so we got reports of people saying, hey, where did all these people come from? You know, people were driving across from one county to the next to get access to the vaccine. And so there's a fear that that's going to happen if we don't get the kind of guidance that Dr. O talked about in terms of segmenting the population and assigning specific vaccines to those populations. And so there's a hope that people get to choose, but then there's also a concern that will also worsen or exacerbate these issues of inequity, because when you have populations that aren't mobile, they don't have transportation, they can't hop in a car and drive 2 counties over, especially with some of our larger counties and access. So I want to just put that on the table for us to keep to monitor. And then also, there's the other side of it where people are concerned that because the Johnson & Johnson's efficacy or effectiveness is lower, that's going to be reserved for historically marginalized populations, that all the whites in North Carolina will have gotten the 2-dose high efficacy, 95% effective Pfizer and Moderna. So we're hearing those concerns, and we're having to counter that with factual, with correct information and allay those concerns. But people think for some reason that the 1-dose lower effectiveness is inferior, and that's what's going to be available to marginalized populations. And so that's why I say the question you need to ask is it good enough to protect me? And and the absolute number sometimes it is. And you bring up another point too, I think, which is important with equity of vaccination, is that we really have to be conscious of the have and have not. I have been vaccinated. I have not been vaccinated, because whenever there's a very scarce resource, that could happen. And I think those of us who've been vaccinated and in those groups need to be cognizant that we should be in all of this as an all-for-one phenomena, including all of the historically marginalized populations. That's right.
And we don't say, okay, I got my ticket to go. And Dr. Cohen had talked about it anyway. It's not safe enough to do that now anyway. But we have to be aware. We have to lift all boats and bring everyone up.
That's right.
And that's a really important thing to keep in mind.
Thank you for sharing that. Dr. Vann, would you like to add anything?
Yeah, I just want to add the fact that we know that in this super fluid world of COVID, we need to try to do as much planning as possible, as early as possible. So we've already started having these conversations with our own internal team members and how we're going to really roll out additional vaccines and additional products. We do know that the allocations are really not going to favor one product over the other. So we're going to continue to receive whatever becomes available, just like we do now. Some weeks we receive Pfizer, some weeks we receive Moderna, some weeks we receive both. So we know that the new products, the Johnson & Johnson and the other ones will probably follow a very similar pattern, but we're asking ourselves the same questions. How are we going to roll it out? And we're thinking about all of the benefits that the Johnson & Johnson, for example, product are going to bring to our community members, having that 1-dose and not worrying about coming back for a second dose. So what are some of those community members that may benefit from that one dose that may be less mobile, let's say, or some of the community members that we can go into their homes, for example, to administer the dose, because we don't have to worry about the logistical challenges with the other two products that are very sensitive to the temperature changes. So we're thinking about all of the different benefits that the new additional products will bring and how we'll be able to take advantage of that, rather than thinking about the downfalls of them. And just like Dr. Ohl said, it's just a benefit of having just another product in making sure that we're vaccinating our community members as soon as possible with these new products coming on board. So we're looking forward to that emergency use authorization and additional information from these new products that are coming on.
Thank you.
And may I add another factor that I hope we can get in before the end, and that's the behavioral health impact, because not everyone is able to make the decisions that that we know are important for better health outcomes and for optimal health outcomes. And so, research is underway and has been done since the onset of the pandemic about the behavioral health implications or consequences of the COVID pandemic. And we know, CDC reported that, published a report or study that found 40% of Americans reported since the onset, since COVID began, a decline in their mental health, whether it's increased depression, anxiety, PTSD, suicidal ideation, and the like. And then also in JAMA, recently, an article found that doctors are twice as likely to die by suicide as their own patients. And this is looking at and rethinking, the article's title, Rethinking Wellness or something like that, in amid rising COVID emotional distress. So found some impacts on the mental health of doctors, medical interns experiencing a 5-fold increase in depression within 6 months of residency. 40% of nurses in their in this particular study reported in JAMA, experiencing extreme lack of empathy that was highly correlated with burnout. And then greater than 60% of pharmacists also reporting suffering from emotional exhaustion and other factors. And then in another article, there was an article that looked at, again, the prevalence of depression among the American U.S. adult population, and found that depression symptoms was more than 3-fold higher during COVID compared to when it was before the pandemic, and specifically among individuals with lower social resources, lower economic resources, greater exposure to stressors such as job loss, evictions, having to work that double duty of parenting and working from home, reported greater burdens of emotional and psychological effects. And so when you add all that in the midst of people having to make decisions about going out and getting vaccinated, that's also something that we need to, I think, put resources around in terms of educating and making sure people have access to peer support specialists. If they have, lived experience with behavioral health conditions, making sure that our community health workers are out there reaching and connecting people to services, because some people are not just going to come up on their own and raise their hand and say, I need to get vaccinated, because they're dealing with all this other stuff. And we know that can affect health seeking, that's affecting their health seeking behavior. So I just wanted to throw that in there.
Thank you for those comments, and incredibly true and important to remember. And on the subject of looking out for one another, we have heard from listeners who are trying to do just that. So in our last few minutes, I'd like to maybe offer some advice or maybe some practical ways people can help out. For example, one of our listeners, I believe it was Teresa. Yep, she is curious about how to help loved ones. This works for anyone, a friend, in another county who might need help, as an older individual and might need some help scheduling things and getting to their appointment. Maybe I wonder if anyone could please tell us about some of the resources or just, advice you would give for people who are wanting to really be community minded and think about others right now and helping out.
I can definitely start a little bit there. So first of all, I think that one of the main points that we need to talk about is in order for everybody to help, they need to continue practicing the 3 W's and making sure that those mitigation strategies are put in place, wearing the mask, washing your hands, staying 6 feet apart. That's how you can help. Then when we're going into more specific actions on how you can help your community, our health department is always looking for volunteers in the community to help with our vaccination clinics with COVID-19 response. We do have information on our website. It is www.healthyguilford.com. And there's a place there for more information about how you can volunteer with us. So please go to our website, reach out to us, and we'll be more than happy to see how we can work together and how you can help your community in these really hard times.
Thank you, Dr. Vann. Yes, we heard from a retired nurse who was asking how she could get involved with vaccination clinics and things like that. So I appreciate it. Anything anybody else would like to add to that?
Yeah, so I'm dropping in the chat some resources. Help for NC, which is a service that was stood up again to help people deal with the mental health and substance use, the behavioral health implications of the COVID pandemic. So that's Hope for NC, 1-855-587-3463. We also have a Hope for Healers, again, recognizing some of the impacts on our frontline healthcare professionals. And then, that number is also in the chat to share with the attendees, and that number is 919-226-2002. And then we have the COVID call center, and people can call to get questions answered about access to the vaccine, about navigating our website, or not even, and especially people who don't have access. There's still a broadband access issues in our rural areas. And so they can call this number and get information. But I agree with Dr. Vann. The vaccine is just one part of our prevention and COVID mitigation response. We have to continue to practice the 3 W's until we get on the other side of this pandemic.
Thank you so much. This has been an hour full of wonderful information, very important for our listeners. And we do want to let our listeners know that WFDD will be following up on, some of the ideas you've given us. They will be shared with the news team, and we will certainly be looking into these important issues throughout the rest of this pandemic. And want to thank our panelists for taking time out of their very busy schedules to be with us and to share their expertise. We really appreciate you all. And we'd also like to thank our sponsors for this virtual community conversation. You heard them at the outset, but I'll let you know again, they were Great Outdoor Provision Company, the Hispanic League, Brook Ridge Retirement Community, and Eben Concepts Employee Benefits. And also a big thank you to our Spanish interpreters, Angie and Murtado. You can also watch any of our previous virtual community conversations online on our website at WFDD.org, and keep those questions coming to us. You can always submit them again on our website at WFDD.org. And thank you so much. We appreciate it.
Thank you for having us.
Thank you. Thank you for having us.